excuse me, for our machine here making that noise. And Kelly, who will go on to tell us about the MHA Peer National Certification Program, which we hope will also open doors to financing peer services in the private insurance market, and you'll hear more about that from her. But first, it's really my great pleasure to introduce Michael Brody of Mental Health Partnerships. Michael?
Debbie, thank you very, very much. And Debbie and Karen, thank you for asking me to join in this very important conversation. I was really thrilled to be able to have a similar conversation, as Debbie said, in Boston this past summer, in which we had a pretty vibrant conversation, not only about peer services in general, but Mental Health Partnerships, MHASP's experience in bringing these services up. So I want to start by saying that, as Debbie said, the Mental Health Association of Southeastern Pennsylvania, now Mental Health Partnerships, has a very long and storied history in peer services. About 35 years ago, a gentleman by the name of Joseph Rogers joined the organization and, as hopefully many of you know, became a national icon in the development of peer services, the development and empowerment of the peer voice in the service system, and created numerous opportunities within the region we serve. We serve southeastern Pennsylvania, so for those of you who are familiar with that footprint, Philadelphia County, Montgomery County, Bucks County, Delaware County, and Chester counties in this region. We also have a footprint in Delaware, and most recently began a collaboration with a merger with the Mental Health Association of Southwest New Jersey. And throughout the development of these services, Joseph and many, many colleagues, including Debbie, brought to life the voice of people in recovery, people with lived experience, creating not just centers for people to come where recovery-oriented services were offered, but those services were offered by people themselves with a lived experience and a diagnosis. At MHP, over 50% of our employees are people with lived experiences and or family members, providing services in a wide range of locations in the community with mobile peer services, and we'll talk about that in a few minutes, in residential services, in case management services, in recovery learning centers, formerly known as drop-in centers, and in our advocacy. Almost everyone in our advocacy department is a person with lived experience, and they bring a tremendous voice and passion to the work that we do. So I'm told I have control over this. Okay, folks, that's me, and a quick look at that. Okay, so where do you start? About 5 years ago, 6 years ago, we had somebody come visit us from a very large national organization because we wanted to think through with them a possible partnership of our training for certified peer specialists. In doing that, the vice president of that organization came and spent about a day with us. And through the course of that day, kept telling those of us at the table, you don't have to talk with me about peer services. I understand peer services. I know what it's about. You know, I'm really interested in trying to figure out the nuts and bolts of this, but I know peer services. We had created an opportunity for her to shadow one of our recovery coaches later that afternoon. And for about 2 hours, she went out into the field with one of our recovery coaches. She came back shortly before she was leaving and departing back to Washington and looked at us and said, I thought I knew what peer services were. I had no idea of the power of peer services. I've just had what we call our aha moment. So I make no assumptions about what people know about peer services and peer support. And I think the first thing that's been very telling for us in terms of bringing up peer services, not just here in Philadelphia for our own organization, but also supporting people across the state in doing this, is the environment for peer services needs to be created. We can't assume that people, A, know what peer services are, what they're supposed to do, what mutual support is, what recovery-oriented work is. And so if you are thinking about bringing up peer support services, I would strongly encourage you to do an environmental scan to ensure that you are and your organization is, or if you're supporting an organization, is prepared for an understanding and the nuances of peer services. Secondly, many organizations throughout my experience have stepped into the delivery of peer services without really thinking through what the training and support, the recovery, we call them recovery coaches, what they will need in order to be able to do their work. So we at the Mental Health Partnerships have a 2-week, 10-day certified peer specialist training class that we run in the 5 counties around us to help prepare people for this work. I want to remind all of us that this is just the beginning preparation for people coming into the world of work. So we support people in learning about recovery. We support people in learning about their own experiences. We support people in learning about what people used to label as wrong, making them strong. We celebrate people's experiences, whether it's in the forensics world, whether it's an experience of homelessness, whether it's experiences with the behavioral health system, because those experiences are what is going to bring their work with other people to life in terms of sharing the best of themselves in the peer support world. As I said, that's 10 days of training, but that's never enough. So we offer ongoing support to our staff in a variety of different ways. One of the things that we learned early on in the experience is not to assume that people have what we would call workplace experiences. So how to come to work on time, how to create a schedule for your work of the day, how to document the services that you're providing, how to speak with other people who you are providing support of the person with. So how to speak with clinicians, how to talk with funders, and how to communicate in the most effective way. Learning about motivational interviewing or the basics of motivational interviewing. These are some of the things that we've over time learned that we needed to offer people as they enter the world of work and continue to enter and continue to do their work. Following that, or alongside of that, we have understood that the people who are going to supervise peers, lead or coach them, need to understand themselves what peer support services are all about and what recovery is all about. We can't make assumptions, again, that the people who are going to be supporting our recovery coaches know themselves what peer support is and how it operates and what the parameters of the work is. We've had many, many people come to MHP having worked at other venues, and over time, as they become more comfortable with us, shared what those experiences were at other places where they were supposed to be providing peer support. And what we find is that when peers are not used well, they do things like sit in a waiting room and open the door to greet somebody, or drive somebody from place to place as a transportation service, or help people meet with people as they're entering the service and sit with them while they're waiting for the service. Every one of those things that I've just described could be morphed into wonderful peer support. So can you imagine if somebody was coming to a clinic for the first time, greeted by somebody, a certified peer specialist, a recovery coach, who helped them understand what the experience they're going to go through is, what the intake process is, who they might be meeting with, and sort of orienting them to the service. That use of peer support would be remarkable, I think, in clinical settings. But what we hear is that that's not been the experience in many places. So knowing what peer support is, how to support folks in that work, and creating the opportunities for people to really dive into the work is something we can't assume that people will know and understand. And then, just like any other profession, ensuring that there's ongoing continuous training and education for folks, training and education about recovery, training and education around specialized peer work. We offer specialized training around people who are older adults, people who are involved in the criminal justice system, people who are young adults, people who identify themselves as lesbian, gay, bisexual, transgender, or other. We have specialized classes ranging anywhere from 2 or 3 days to dive a little bit deeper into working with those special populations with peer support. So there's a whole overlay that we think is very important as you move into thinking about the delivery of peer support and delivering peer support that we would want people to consider. We in Pennsylvania have a waiver to provide Medicaid-funded peer support. We are very fortunate in that way. We are one of the number of states that offer that. And so we were very, very lucky in 2006, 2007 to partner with the Office of Mental Health and Addiction Services in Harrisburg to create the peer support service. For those of you who know the fee-for-service world, you know that with blessings come curses, and we can talk about them for a second. Some of what I'm going to talk about now is going to sound like I'm down on this. Let me preface anything I'm about to say that I think peer support services are one of the most remarkably magical services that anybody receiving mental health services could ever have in their lives. We believe that the peer relationship is an opportunity for true personal transformation and systems transformation in terms of the creation of recovery-oriented systems of care. I was just commenting to Debbie and Karen before we got on the call that last Thursday we spent the morning with all of our recovery services asking them to tell us stories about what our peer services are doing in the community. And for a full 4 hours, there was wonderful story after wonderful story that if there's time in the end, we can share some of them. So what I'm about to say has nothing to do with me feeling that peer services are not valuable. What is challenging, though, is the environment, the financial environment, and the fee-for-service environment that we need to work in. So if you are moving into a fee-for-service environment, the rate is critically important. We need to be able to make sure that whatever team gets created is in fact able to be paid for. And that is a very challenging thing right now, especially given that I'll jump to the last bullet, that the Center for Medicaid and Medicare Services is very clear that it will not pay for what they call transporting people to and from locations. So if a peer goes to their participant's house, picks them up, and accompanies them to a clinic visit, and through that car ride is talking with the person about what that visit might entail, how they're feeling about that visit, what are the objectives that they want to achieve in that visit, what are they needing any support from the recovery coach to help them remember. That entire conversation in that car, moving to that clinic, is a non-reimbursed service. As one of my board members aptly put it, if they got out of the car, had that conversation for 20 minutes and got back into the car, that 20 minutes outside of the car would be reimbursable. So the challenge that we've recently come up against is how to ensure that the rate we get paid covers that administrative or non-reimbursable time that our peers are spending with people. Point one. Point two is the team size. So in Pennsylvania, there is a requirement and regulation that in every county there be at least 2 peers available for the population of that county. That was a minimum floor that was created because there was tremendous consternation amongst many of the rural counties around how they were going to bring up peer support. What we have found is that it takes a minimum of 4 recovery coaches on a team of up to 7 people for that team to be financially viable. So when we propose the creation of a fee-for-service team, we say to our funders that if there is no other monies available to support this team, the team needs to be at least 4 to be able to be financially sustainable. Within Pennsylvania, the regulations say that the team can be comprised of up to 7 recovery coaches and 1 supervisor. So you can go as high as that number, and when you get to the 7 number of 7 coaches, the team in the past has been very financially sustainable, in fact offering a little bit of a profit or margin for us in regards to the provision of the service. We've also found that there is a ramp-up and time to get a team running and fully operational. That ramp-up time is anywhere from 12 to 18 months, depending upon the nature of the geography you're working in. So, for example, in Philadelphia, a very urban setting where there was a large nexus of need and a significant number of people looking for the service, the team that we brought up was financially self-sustaining within a year and was very successful in terms of their ability to do the work and to be financially feasible. In Bucks County, which is a very rural county and very large, that team took anywhere between 18 to 24 months to become financially sustainable, and we required some program or county funding to support us through that time. Some of the challenges in that county were the wide geography and getting to and from people and trying to figure out how to assign caseloads and workloads to the team so that they weren't driving long distances to meet with people. Another challenge was getting enough referrals for each recovery coach to have the size workload that they need. Every recovery coach that we hire has a workload of anywhere between 12 to 16 people that they work with at any given time in a standard adult peer team, as some examples of how we've structured the work. So thinking about that ramp-up time and that's whether or not startup funding is necessary is another consideration. And finally, staff turnover. And what I want to say about staff turnover is that we know in the world of behavioral health direct services that there is significant staff turnover of direct care staff. So whether you're talking about case management, whether you're talking about residential services, whether you're talking about day settings, that the direct service staff has a significant turnover. We don't think that the turnover, our experience is that the turnover for peer staff is no different than that other workforce. But we've experienced over the course of time that people start the work with a great deal of passion, a great deal of enthusiasm, and a great deal of excitement, and then find out that it's work, and that they need to get up on time, they need to be here, they need to have a certain level of productivity, they need to be able to document those services, and that within approximately the 6 to 8 months of employment is when we start to see whether or not there's going to be traction with somebody, whether we're going to be able to sustain them, support them so they can go on, or whether or not they are not going to be successful. In our work, it's a typical fee-for-service environment. So for those of you who are in that environment and know, we need to do what we call our life story, a psychosocial assessment. We need to develop a recovery plan in collaboration with the person we're supporting. We need to document in encounter or progress notes in a collaborative fashion the work that we are doing. All of that is what generates the reimbursement for that service. So ensuring that staff are getting the support that they need to minimize turnover is critical. We are looking at some alternative funding options given some of the recent challenges around transportation with peer support services. The most interesting one that we're having conversations with our behavioral health managed care company in Pennsylvania is what we're calling value-based case rates. So we all know that the behavioral health system is moving towards value-based payments, payments for outcomes, and the managed care companies in Pennsylvania are no different, and nor, frankly, is the Office of Mental Health and Addiction Services any different in terms of wanting to see a move towards value-based payments. From the behavioral health managed care company's perspective, what they place value in terms of the outcomes they're looking for is reduced hospitalizations, reduced use of crisis services. If people are going into the hospital or crisis services, shorter lengths of stay in those services, and participant satisfaction. Magellan Behavioral Health did a survey of ours and other peer services in the 4 surrounding counties of Philadelphia, 3 surrounding counties of Philadelphia, and found that the addition of peer services had significant impact on all of those items. So there was significant reduction in hospitalizations and length of stay in hospitalizations, significant reduction in use of crisis services, and high rates of satisfaction with people receiving those services. And so we're looking to thinking about doing is moving to a case rate. So that's a monthly per member per month payment that we would receive, and trying to achieve some outcomes by providing that service. The other way is to just have case rates, which don't have those outcomes attached to them. Quite frankly, I would be surprised if any managed care company or any state would move in that direction without the value base attached to it, given the move for that. And then finally, program-funded services. So that is how we started our recovery team in Philadelphia. The city of Philadelphia funded us at a program rate, so we sent them a budget, what our costs were. They paid us for those costs for the first year in order to bring the team up and make it viable. That, quite honestly, was extremely helpful for us in terms of bringing that team to life. I think that, in part, was why we were able to get the team as self-sustaining as quickly as possible, because they were not chasing the units, which is what you tend to do in a fee-for-service environment, and folks were able to get a great foundation under them as they provided the service. Those are the 3 other funding mechanisms that are presently available from my perspective in order to make this happen. I would encourage any of you that are thinking about moving towards some level of Medicaid-funded peer services to explore the value-based case rate sooner than later. one of the challenges that we've always had with our peer services is trying to ensure that the productivity of our recovery coaches matches what our needs are. Right now, about 50% of a person's work day is non-billable, so it's documentation, it's travel, it's training, it's vacations, it's holidays, it's sick leave. The remaining 50% is what we call productive time. And so people have had to learn how to figure out if somebody cancels an appointment, who else might they see that day, who was in need, do they have a backup plan. Much of that goes away if you can move into a value-based case rate system, which is what we're hoping to be able to do with Magellan in the 3 counties that we're in. So I'm going to stop at this point and thank you for your attention. I know that at the end, after Kelly has a chance to spend some time with you, we're going to offer you a chance to ask any questions. And I appreciate your interest in this. I appreciate your excitement in thinking about developing peer services. As I said, they are magical and transformational, and I'd really strongly encourage each and every one of you to take advantage of what could be life-changing for people. Thank you very much.
Thank you, Michael. That was very informative, and I just want to share with folks that I was at a meeting this morning where we heard CMS Administrator Seema Verma speaking, and absolutely under all of the Medicaid as well as in much of the private insurance market, things are very much moving towards value-based payments. So just want to stress what it is that Michael had said. Kelly will be talking about how to use peer services in both environments and an opportunity for our MHAs to get in on doing some training and some more things that will help their bottom line. It's with great pleasure that I introduce my colleague, Kelly Davis. Kelly is a terrific colleague and a person with lived experience with a mental health condition and trauma, and that's really what informs her passion for helping folks who are really trying to figure out how to receive a full spectrum of supports and services. As we said earlier, Kelly is our Manager of Advocacy and Peer Services. She's really passionate about her work in all areas, especially trauma-informed care, obviously peer support, person-centered care, and civil rights. This is why she spends a lot of her outside time writing about experiences and helping people obtain wellness through teaching yoga and fitness classes and facilitating peer support programs. She also is working on some terrific programs around college and college individuals and peer support on colleges. So I'm going to introduce Kelly and tell you a little bit more about how she is working with our affiliates all across the country on our certification program. Kelly?
Awesome. Thanks, Debbie, and thank you, Michael. That was awesome. Let me see if I can, let's see, it looks like I have control of the, there we go. Okay, so that's me. And so I'll just get started. Let me go back. There we go. Oh, this is not working. Here we go. That's weird. I don't know if, Karen, you can help me on this. Can we, sorry.
We're working on it here, Cal.
Yeah, there we go. Thanks. Huh. That's really weird. I want to stay on number 5.
Let's try it again.
Okay.
There we go. How's that, Cal?
All right. It's skipping the slide. If we can just leave it like that, I can just make do and then move from there. So as Michael said, peer support works. So starting with where we are. So improves outcomes, improves quality of life, and reduces the use of the most expensive and intrusive services like inpatient. And peer support certification is growing. So as of last year, there's over 26,000 certified peer specialists across the country working And that doesn't include non-certified peers, so people who don't have their state certification who are doing peer support work, and also doesn't include states without certification like California. So, you know, Patrick Hendry, who's our VP of Peer Advocacy Supports and Services, estimates there's over probably 30,000 now people doing this work. But unfortunately, lots of people who are really great or who really enjoy working in peer support leave the workforce, citing lack of upward mobility or pay scales. And it's kind of generalizable to any type of profession. Recent research shows the #1 reason people leave their jobs is a lack of upward mobility in addition to pay. Because you're looking at people making anywhere from $20 an hour, you know, with benefits, versus some places where people are being paid minimum wage, who maybe want to work full time, who want to get off disability, but don't necessarily have the opportunity to do so. And go to the next one. Awesome. So I work on our newly launched in March MHA National Certified Peer Specialist Certification. So it's the first National Advanced Peer Specialist Certification. And the goal is, or two of our goals are, more career opportunities for peers and expansion of peer support into the private sector. So we've created high uniform standards with our group of experts over the past few years. So we require 3,000 hours experience, minimum of 40 hours training, and an expanded knowledge base that includes things like trauma-informed care, adult learning, and knowledge of the private sector. So why we did this is because when we were working with the private sector, that's been showing increasing interest in peer support and better opportunities for wages and career mobility. They were saying that, you know, they needed higher standards than you saw in certain states, and they wanted to know that they were getting the same type of peer support no matter where they were across the U.S. Okay. So I'm having a little trouble with the. No, I'm going to go back. Sorry. Let me see. Karen, do you mind going back a slide? It's not.
Sure.
Letting you change it. Cool. So opportunities for affiliates. So to start off with some of the misconceptions around the certification. So the certification is examination-based. If you have the experience, if you have the state certification and or the minimum training hours, in addition to employment verification and letters of recommendation, you can qualify to sit for the examination. So opportunities for affiliates would include training trainers around some of the trainings we endorse. So right now our training partners include the Institute out of MHP. Another one of our partners is the Appalachian Consulting Group out of Georgia. And then we also have relationships with DBSA and Intentional Peer Support around training organizations. We have some really cool things coming up. We have verbal agreements around doing some joint work with the biggest trainers in the country. So that's going to be some exciting new news for us and potentially for affiliates as well. One of the other opportunities for affiliates would be to work as testing sites. So because we're examination-based, the exams are remote. So we find people from all over the country, and then we connect them with local sites where they can go and sit for the exam. So some of our affiliates are taking a training and then administering tests. Train, hire, and place is another option where we work with affiliates who have peers or who are interested in hiring peers and use their connections with the local resources and community to hire peers and then place them. And we have a couple partnerships that I can talk about where we've worked in Northern California and Florida in this way. Then again, working with training partners like I mentioned earlier, so different opportunities there, then consulting around peer support, and then opportunities for peer supervision. So as I think Michael mentioned earlier, so we want to have more than one peer in different settings, and then that career mobility, so having peers, supervising peers, because they understand what peer support is, you know, in a different way than somebody who's a clinician would. So using the hire, train, and place model, some opportunities for affiliates would be to employ MHA NCPS certified peers and then contract out their services to agencies providing health services. So these are just a number of different examples. In our pilots in Northern California, we worked with Kaiser Permanente and one of our affiliates. We're in the process of creating a pilot with Sutter Health. And then in our pilots in Florida, we're working with one of our affiliates in Palm Beach County, and we are partnering with 2 of the local inpatient units for HCA, or Hospital Corporations of America. Can we go to the next slide?
Having a little technical difficulty. We're working on it. We'll have it up for you in a second, Cal. There you go.
Awesome. So affiliates, here's some different ways that affiliates can get involved. So providing the services of the peers to meet the behavioral health needs of people in recovery, peer support consulting services, providing trainings, mentoring. Peer support for peer support staff is another opportunity. There's some people working online to try to figure out how to offer peer support for peers themselves in terms of their professional life. Ongoing educational opportunities. So for the certification, we have continuing education requirements. I know a lot of affiliates do webinars, and people working as peer supporters can certainly use those towards their continuing education requirements. Another thing would be providing office support services for peer staff and providing administrative supports for the full range of contract requirements. So these are things that have happened in our current pilot. So a little bit about, in Northern California, we worked with Kaiser Permanente to have our peers who worked and are supervised by one of our affiliates to go in and support people with complex medical needs in wellness coaching, figuring out their mental health needs, but also figuring out their medical needs, what they need in the community, what would help them both best maintain their recovery. And then with our Florida affiliate, something similar. So we work with the Florida affiliate who employs the peers who are going into the hospitals, meeting people in the hospitals, and then helping them transition into the community and following them for 3 to 6 months after they're discharged. And then some of the values, so the MHA brand, peers trained to the highest standards. So again, this is the first national advanced training. We have the highest standards of any training in the country, and really looked for trainings that we approve to really meet kind of the ideas about civil rights and all the things that we care about as an organization. They're more experienced. They have the wider knowledge base with the knowledge of trauma-informed care, the knowledge of the private sector, and things like adult learning and motivational interviewing. We have a legally defensible certification. So again, addressing some of the concerns about the private sector with, introducing peer support, because we've worked with the certification board in Florida. Ultimately, we'll have a legally defensible certification, the administrative support from affiliates, HR support, supervision, ongoing training, payroll, and office services, so that the affiliates will employ the peers and then work with the hospital systems or the private systems. So in terms of partnerships and the way we've figured out how to work with affiliates, we've utilized affiliates and some of our national close connections with behavioral health providers. So for example, one of our board members works with Sutter Health, so that's how we got linked with Sutter Health in Northern California. and then also utilize the affiliates brand recognition in their community, because lots of affiliates are already doing really great work with peers, and if they aren't working with peers, they're doing a lot of work supporting their communities. We have our MHA developed marketing materials. So online you can see we have comprehensive research on different components of peer support, why peer support is effective, different places you can find it. We've just created a document that's going to be released about how peer support looks across settings, so whether that's primary care, transitional services, inpatient, outpatient, or standalone services. The cost effectiveness and quality of life benefits of MHA peer support. So we were able to show dramatic reductions in rehospitalization rates and in quality of personal outcome measurements and depression in our pilots in Florida that are really helping to build out the already existing evidence about what we know peer support does. Continuing education, full services and support. So basically the affiliates have some opportunities to work with us around partnering with local groups interested in peer support. And we've really found a lot of interest in the private sector. If you go online and look at Indeed or anything, people like Anthem and Optum are all increasingly employing peers and looking to employ peers. And our certification is a response to really hope to get not only more peers into the private sector where people are, but also to have better, sorry, I'm trying to get this next slide, better quality of life and better outcomes for the people who are providing the peer support themselves. And
thank you, Kelly. We're going to unmute everybody, and if you have a question, please, when you ask your question, identify yourself and also identify for whom the question is directed. So, whoever wants to get us started, please do.
Hi, may I go? My name is Jeanette Garcia from the Mental Health Association in Wichita.
Go ahead, Jeanette.
Sorry, I joined in late. I'm on Central Time and kind of got on here late, but I did have I don't know if you all know, but in the state of Kansas, we used to get funding for peer support training, just the certified peer support training, and the state stopped giving us funding. So it would be quite costly just to even get our peers trained. And I'm not really sure. I kind of came onto this program not too long ago, so I'm not really sure how to help my peers. We talked to the state, and we do have a training in place that kind of, goes with what WSU in town was doing, the Wichita State University. That's who provides the training. But just to even get them the basic training, we're struggling because it is quite costly. And then with this other information that you're providing, I guess I just want to find out about cost and all that kind of stuff.
Kelly or Michael, would you like to address the question from Jeanette?
There is no simple answer, obviously, to a lack of monies to do the training. I guess I would encourage folks who are trying to find the resources to be able to do this to reach out to health foundations, possibly hospital foundations. I think, as Kelly said, there's tremendous benefit to hospitals and insurance companies who for them to support peer support in terms of reduced hospitalizations, bridging people out of the hospital so they connect to care. And so ways to think about getting them to understand that there's bang for their buck if they invest in the peer support training, such that they get a trained workforce that can do those kinds of things, are some of the thoughts that I'd have around that. I empathize with you. We run up against that as a training vendor with people wanting our training and trying to figure out ways to pay for that are challenging. Hope that's helpful.
Yes, thank you very much. I appreciate your answer.
We got a question that came in through our chat box, and the question is, how would things work with peers working in co-occurring situations and in the substance use world? Would Michael or Kelly like to address that?
Well, a couple of things. In Pennsylvania, again, we are very fortunate that parallel to the CPS, there's a credential called the Certified Recovery Specialist. Some of the national certification that Kelly was talking about for CPSs is modeled to some extent after the CRS, where people have to demonstrate a certain number of hours of work and education to apply for the certification. In Pennsylvania, many of the behavioral health managed care companies offer payment for certified recovery specialists as an adjunctive service, and we are actually about to launch a duly certified team in Delaware County, where some of the staff will be certified peer specialists and the remainder will be certified recovery specialists, offering services to people who identify with a primary substance use problem. And I think it goes without saying that a significant number of people that our CPSs are working with are people who are duly diagnosed, and a significant number of our recovery coaches are they themselves people who were challenged by a dual diagnosis and bring both experiences to bear.
Thank you, Michael. I just want to have a reminder to anybody who joined us late. We will be posting the slides as well as the recording to the webinar, and Karen will be sending everybody an email telling them when those are posted. Other questions, please?
Debbie, can I also just quickly answer as well?
Sure, Kelly.
So in terms of our national certification is specific to mental health and isn't explicitly created to address there's some about co-occurring, but it's not specific to addiction. One of the things that we've talked about though, and Michael touched on that already, is the prevalence of co-occurring disorders, but also a lot of the fundamental things that we're asking people questions about and testing the skills around, like motivational interviewing and, talking to people about their whole health, and all of these things that we focus on are really kind of applicable to both sides. So I think that a lot of the skills that we're talking about, just make somebody good at supporting other people, and then having that lived experience with addiction or with co-occurring disorders just adds to being able to help more people.
Thanks, Kelly. Other questions from folks on the call?
This is Barb. I'm in Dallas, and I was wondering if there's somebody that I can chat with regarding the services in Dallas. We have a large pool of trained substance use disorder certified folks, and would like to implement the mental health training, and I'm not sure exactly yet with our state laws how different they are, and so I didn't know if there's somebody I could talk to specifically that might have some experience in figuring that out.
Well, I could possibly connect you with a colleague. Not possibly. I could connect you with a colleague here in our region who works for the Council for Southeastern Pennsylvania, who probably has a lot more experience than I certainly have in terms of how the CRS came about, what that process was, how they've had conversations with the behavioral health managed care companies about bringing up those services. Bev has a tremendous wealth of experience and might be able to be helpful around that question.
Fantastic. I will shoot you an email right now.
Great.
Michael's email will be at the end. Go ahead. I'm sorry.
This is Glenn in New York. Question for you. How do you collaborate with existing providers in the States? We have a lot of existing, obviously, peer groups here in New York. How do you collaborate with existing programs through the national lens?
Are you talking about the national certification, Glenn, or are you talking about?
Yeah, how do you work, how does the national certification process work with existing structures that we have throughout New York?
Can you be more specific in terms of just getting people certified, in terms of?
Yeah. Is there like, I'm new to the certification process, so I just want, there are different processes. We have a process in New York. There's a national process now that through the national MHA. How does it go about? How do you guys collaborate? How do you work together on that?
So it kind of depends on the state, but one of the things that we're really clear about is that it's an advanced certification. So if you're in a state that already has a certification, you're required to have the state certification. And we're not looking to kind of circumvent or to take the place of the certifications that help people get reimbursed for Medicaid services or however the services are paid for. That's more a way to show that you have the higher level of experience and knowledge base to work with the private sector. So it's not kind of taking over, but we have relationships and, working personal relationships with the different peer groups in the different states around people who are interested in expanding beyond what they're currently doing now.
Thank you.
Mm-hmm.
And I would just say, I'll just say as a personal plug on the national certification, we're really, really happy to be partners with MHA on this and think it was a tremendous advance. We find many, many people who we train have challenges in terms of going elsewhere and being able to carry this Pennsylvania certification forward to other places. So I think this is a tremendous advancement in terms of the profession as a whole.
Thank you, Michael. We have another question that came in through our chat box that I think might be best directed to you. The question is, would a value-based case rate, how much per person per month, and what does that translate into with respect to client contact?
So we are just stepping into that concept, and I'm not sure if the person is asking how you come up with that, but the way the case rate is basically calculated is to determine what our costs are, what margin is we're trying to achieve out of that program, and then creating and negotiating with the behavioral managed care company a per member per month fee that we would be paid every month on behalf of folks. We still need to do the same kind of documentation in terms of attesting to the services that are offered, the amount of time people spend with people. But as I understand it from talking with others, the value for us is that, again, we're not chasing the unit, as I described before, and the value for the behavioral health managed care company is on some level they've got a fixed cost that they're paying out every month, and so their costs are more predictable for the year in regard to the payments they're going to be making. And they're very interested in the metrics that we were talking about and the ones that Kelly mentioned in terms of hospitalization and things of that nature to tamp down on behalf of their members, because it saves them a great deal of money for those high-cost services. I'm not sure if that's the answer the person was looking for, so hope that was helpful.
Thank you. We have time for one more question, but that doesn't mean that folks aren't willing to answer more. You see Michael's email address and Kelly's email address, and both of them will be happy to have questions about the certification in particular to Kelly, questions about how to operate in the fee-for-service, or historical questions to Michael, or anything else you'd like. And we got time, as I said, just for one more. Is there anybody who wants to ask a quick question? Well, hearing none, I'm going to thank all the affiliates who joined us today. We had more than 50 different affiliates today join us. We're very happy that you could, and really express great appreciation for Michael Brody, both for Mental Health Partnerships, for their historic role, for their current role, for Michael's willingness to share with us and of course for our colleague Kelly Davis, who is doing a wonderful job in helping share the national peer certification, and any questions about that can be rolled out to Kelly, and also we can direct to Patrick Hendry, our Vice President of Peer Services. So again, this is Debbie Plotnick, and I want to thank you all for joining us, and we look forward to more webinars in our Regional Policy Council series, and we'll look forward to having you next time and at the meetings as well. Thank you so much.
Thank you.